Dr. Elizabeth Yurth, welcome to the Biohacking Secrets Show.
Thanks, Anthony. Thank you for inviting me.
All right. So you work at the Boulder Longevity Institute, but for our listeners who may not be familiar with your work, share with us your origin story and how you got into this.
So I think I came from a little different world than a lot of doctors who do this kind of medicine, but I am actually trained. My background is in orthopedic medicine, and I practiced orthopedic medicine for the past 27 years. About 15 years ago, I became sort of frustrated with, wow, okay, we fixed your shoulder, and then it was never really better, but we said, well, it's good enough. That's as good as it's going to get. And then something else would fall apart. We go, well, that's as good as that's going to get. And we would just sort of, as one of my old partners used to say, he's like, after 50, it's just patch, patch, patch. And, and so it was kind of this frustration with, I'm tired of patching and not repairing. And so I started to look at how can we actually repair things. And that got me down the road. And this was back when people weren't really doing this that much. 15, 16 years ago was sort of A4M, American Academy of Anti-Aging Medicine, was just getting its start. There was not thousands of people at the conferences like there are now. So basically I went and I looked for how can I learn on health a little bit more. So I went and got a fellowship in functional medicine through A4M, learned about how hormones affect healing, how health affects healing, and started kind of preaching that to my patients that, I can help you with your shoulder, but honestly, this is a sign of underlying other stuff that we need to address. And then realized I can't do that in 10-minute appointments that were paid for by insurance. So we opened Boulder Longevity Institute and said, come here, we'll talk to you about this stuff we can't talk to you about here. And so I've been kind of playing both hats for a long time, where I put on my orthopedic hat all day long and I see these patients and stick steroids in their shoulder and then tell them that's really not the best thing to do. And then see them over at my other clinic at Boulder Longevity Institute, and we try and actually fix their health. We look at, all the other factors, and we try and educate, paramount to that, try and educate people so they understand disease processes better. And then really more recently, I actually left my orthopedic practice. I just brought it over to Boulder Longevity Institute, where we still do a lot of regenerative orthopedics, but I've stopped putting steroids into people all the time. And I've stopped doing the things that, really quite frankly, I don't think are the things that are going to help them heal. And we've gotten a little bit more of a focus on education. So we have a whole, what we call Human Optimization Academy now that you can sign up for through Boulder Longevity Institute, that actually we are trying to teach people about understanding these disease processes in a whole different way. We sort of gave up with trying to teach doctors. We realized that wasn't getting us very far. And that when you tried to tell a doctor to do anything differently from what they were doing, they didn't really want to listen. But people do. And hence, that from your podcast and the people you work with. A lot of
doctors too. But I know what you're saying. Yeah, some. I only see the ones that do.
Yeah, you probably, and I see the ones who don't.
Yeah, exactly.
So it was interesting. Yeah, my orthopedic practice, one of my doctors said, he said, you're spending too much time with the patients. You need to be seeing patients faster. He said, we don't do medicine here. We do orthopedics. Yeah. I thought that was a pretty classic statement, So orthopedics should be medicine first and not just, fix. Obviously, if you break your bone, hammers and nails are great. But if you have an arthritic joint, they're not. And so we're trying to teach people a little bit more information, which is changing constantly. Hence, the people like you who are out there trying to educate people are so useful, so people can get this information and we can get this information out there. So I appreciate what you're doing.
Yeah, I appreciate what you're doing as well. And before we kind of get into some of the anti-aging stuff and really helping people get back to basics, because we were chatting a little bit how it's easy with all the information out there to kind of develop a nice case of new shiny object syndrome, and then you're doing the whispers, but you're missing the shouts. And we'll kind of get into that and what those are and what are some of the patterns that you're seeing a lot. But first, how would you kind of describe? I'm going to take this. I'm going to get a little bit more specific. So a lot of people aren't familiar with books like the Arthritis Breakthrough, which essentially theorize that many arthritic conditions are related to low-level bacterial infections that respond well to like an antibiotic like minocycline. And there's tons of stories of people who have been bedridden, taking 100 milligrams of minocycline twice a day and their problem goes away. But then people that are kind of in this world, they're like, oh my God, antibiotics, anti-life. No, can't do that. You know what I mean? Then you go a little bit deeper and you find out, well, some antibiotics stimulate exosomes and this can, cause a healing cascade in the body. So how would you kind of, for our listeners that want to get caught up on what you believe to be the truth in orthopedics right now and what works and why, Fill us in on what you've seen, because you're in the trenches doing it.
So what we really are thinking now is that degenerative diseases, osteoarthritis, is no different than somebody who has degenerative cardiac disease or degenerative brain disease, and that they all are at a level of cellular dysfunction. It's just different organ systems that are involved. We know that people who have osteoarthritis have higher incidence of cancer and they have higher incidences of dementia. So we do know that there's overlap to all of these diseases. Now, we know that low-grade bacterial infections play a role. Probably low-grade viral infections probably play a role. But ultimately what we're seeing is these are inflammatory processes. So I hear all the time, oh, well, as a football player, that's why my knees are bad, because I trashed my knees because I played football. Well, not every football player has bad knees. So there's a lot of genetic bias and just health bias that create changes in these inflammatory cytokines inside our joint. So if you look at an arthritic joint, there's different levels of inflammatory cytokines. So we know we have these pro-inflammatory cytokines and anti-inflammatory cytokines. So for your listeners, cytokines are little proteins that tell our cells what to do. And so if I have very high levels of interleukin 6, for instance, and tumor necrosis factor alpha, either somewhat genetically, but a lot of times lifestyle, stress, sleep, all those things play a role in those inflammatory cytokines. And I get a minimal little injury to my joint, it actually starts this tailspin process. So we now know that there's this one interleukin called interleukin 1 beta that some people genetically have high levels of, but there's also, again, maybe bacterial influences, maybe environmental influences that will raise interleukin 1 beta. And for instance, a study just came out with degenerative discs where they took mice who were bred for very, very high levels of interleukin 1 beta, and they blocked interleukin. What they did with the high levels, they stuck a little teeny pinhole into the disc. And they saw within days that disc went from a normal disc to a completely degenerate disc. Ooh. So what they saw is that the interleukin 1 beta got inside the cell. It actually caused the nucleus to produce something called NLRP3 inflammasome, which is a bad thing. Sounds like bad, and it is. Mm-hmm. That NLRP3 inflammasome went to the mitochondria. We're going to talk a lot about mitochondria today because I have a fascination with them, but it went to the mitochondria, actually caused destructive changes in the mitochondria. Mitochondria produced all these reactive oxygen species, started killing the other mitochondria, and you saw this rapid degradation of cells, right? So can bacteria do the same thing? Yes. Can viruses do the same thing? Yes. So injury, viral loads, low-grade bacterial infections would cause this upregulation of inflammatory cytokine. If they blocked interleukin 1 beta, then they could stick a hole in the disc and it didn't do anything. So and the same thing was shown true for cartilage and joints. So we know that these inflammatory cytokines that are dysregulated are playing a big role in this tailspin of production. And if you listen to any of the stuff on senescent or zombie cells, right? Once you have one bad cell, it kills a few others, and those kill a few others, and those kill a few others. And that's why there's this big downhill spiral.
Yeah, so instead of focusing like an episode of Walking Dead.
Exactly. I mean, it really is. And so instead of focusing on scoping a knee, because what have I done when I scope a knee? All I've done is destroyed more cartilage and created more inflammation. You've got to change the cytokine response. Mm-hmm. So we're using things that, block interleukin 1 beta, like high-dose melatonin, mm-hmm. or epigallocatechins, which is in green tea, or pentosan polysulfate, which is used in Australia a lot for arthritis, to block the inflammatory cytokines, and then doing things like putting in platelets or stem cells or exosomes and seeing very marked repair. So we know this is an inflammatory disease process just like everything else.
What was that substance that you mentioned from Australia?
So there's a medication called pentosan polysulfate, which I love, and it's actually approved in Australia as what they call a disease-modifying agent for osteoarthritis, meaning they think it's a cure for osteoarthritis. And it basically, they took patients who were headed to joint replacements, to knee replacements. They put them on pentosan, which is it's a drug. It's not a peptide. It's really or a supplement. It's actually a drug. It's a pharmaceutical. And they put them on pentosan, and 9 out of 10 of them had enough improvement that they canceled their joint replacements and continued to show improvement over time.
Come on.
It's pretty remarkable. I mean,
what dosages?
So what you do is, so this is actually a drug here in the U.S. called Elmiron, but it's oral. And it's used for bladder cystitis. So it's used for bladder inflammation for some of the same reasons. It blocks the inflammatory cytokines. The problem is orally, it has 2 downsides. Number one, it doesn't seem to have any benefit for joint cartilage. Number two, over about a 15-year period, people on Elmeron, they notice some retinopathy to the eyes. And you don't see that with the injectable. So what you have to do is you have people—
Which probably isn't a good reflection of what it's doing to the mitochondria either.
And well, maybe there may be a different reason for that, but the Pentacin done subcutaneously or intramuscularly, or maybe intraarticularly, we haven't used it that way yet, not available that way yet, actually worked very nicely to block. So it's actually used for cancer. They're looking at it as a research for cancer as well for the same reason, to block all the bad inflammatory cytokines, upregulate the good inflammatory cytokines, and actually repair cartilage defects. So people who have bone contusions, fractures, or just osteoarthritis, what you have them do is you have them do an injection themselves, just a little subcutaneous injection once a week for 6 or twice a week for 6 weeks, once or twice a week, depending on their size, for 6 weeks. The dose is dependent on patient's size, so we dose it dependent on their size. And then after 6 weeks, usually you've gotten a nice little improvement, and then you have them find a dose that helps keep them regulated. So for me, I have bad arthritis in my knees. I've had 4 ACL reconstructions. I finally gave up on that and just said, I'll just brace my knees.
I was having knee surgery. I had 2 knee surgeries in college soccer.
Yeah. I tore my knees.
Half of the 4 years.
Yeah. And 80% of people have ACL reconstructions, even at that age, at 18, 80% are going to develop osteoarthritis by the time they're 50, 80%. And we're doing nothing about that. We should be treating those kids, and that's what we're doing. We're treating those kids at the time that they have the ACL tears. So hopefully at 50, they don't end up with horrible knee arthritis, right? So you can preventatively treat those kids even with Pentacin or epigallocatechins, things like that, so you don't end up with the osteoarthritis down the road. But what we saw is, you can repair this because you're not getting these high levels of interleukin-1 beta. You don't get the mitochondrial dysfunction. You don't see the progressive cartilage loss. So I do Pentacin once a week. I just do it continuously once a week. I have patients who can go off of it for a while, go back on it, or do it once a month. But it's pretty remarkable. They're also looking at it for actually helping people after ACL reconstructions because it helps that bone tendon interface when we do ACL reconstructions on patients. And they're looking at in a prostate cancer study, it's kind of a remarkable and relatively, in the scheme of some of the things we do, inexpensive substance.
Wow.
So we're doing, for instance, it's in my mind why regenerative therapies like stem cells and platelet cells have a little bit of a mixed bag. Is if I'm taking your cells and putting them back into the same environment that got you there in the first place, probably not going to make much headway. So you've got to treat some.
What if they're from a little healthy African baby? I'm kidding. I'm kidding.
I mean, that's probably better, right? And that's where exosomes come in.
Yeah.
Because exosomes, then you're using from umbilical sources, but you really have to get the body in a healthy state, and that's we're getting the interleukins more balanced. Pentacin's one of our ways of doing that. But on a simple perspective, you can use things like EGCG or epigallocatechins, which will also down-regulate interleukin-1 beta, upregulate. You
do that orally?
And you can do that orally. We're looking at actually doing an intra-articular injection because that seems like that's going to be, at least in mice, it was super helpful. So we're working with a company now to see if we can develop that. But in mice, injected intra-articularly, it was really marked improvement in cartilage. But orally, you can see pretty dramatic improvements in people too with osteoarthritis. So we have people do, and epigallocatechins have huge anti-cancer benefits.
Great for like everything.
They're great for everything. They raise follistatin so you can have build muscle,
pathway.
Right? Yep. So I'm a huge fan of those. I think we're looking for other ways. If you get to high dose epigallocatechins, the big risk is that you actually can affect liver function a little bit. So we're working with maybe developing transdermal, something like that, where we can do something to get them bypassed by the liver.
Okay.
So there's some really simple tools that you can use that are working at this cartilage level. High dose melatonin too. Low dose melatonin doesn't seem to have the same effects.
Right.
But if you get up to like 20 milligrams of melatonin, in the mouse study, that's what they used to block interleukin-1 beta and had really dramatic effects. So all your listeners, back pain is horrible. Like it takes out a huge amount of our population.
Yeah.
And degenerative disc, we have nothing to offer you except fusing your back. And you can put somebody on high dose melatonin and see pretty dramatic improvements in back pain. And epigallocatechins the same. And that's interleukin-1 beta.
Dr. John Lawrence has a 200 milligram melatonin suppository and he makes them with a bunch of other stuff, and they're fantastic. I'll use that once or twice a week and just like zonk out for 8 or 9 hours, and it's great. But I'm really excited about this Pentacin, especially because
Pentacin is cool, and nobody knows about it. And if you look at a company in Australia that makes this called Paradigm Pharmaceuticals, and if you look at their research, it's really compelling. And it's, we can get it made for us here because it is a drug. So it's an FDA approved drug here. So it's very simple for us to get a pharmacy to make it for us and compound it in an injectable form. You have to know where to get it. But, it's been used in the racehorse population for years. Racehorses have gotten Pentacin.
They're always on the good stuff.
They're always on. Isn't it interesting?
Yeah.
I remember back when visco supplements like Synvisc, which are hyaluronic acid, first came out, I'd always force people who brought me their horses visco supplements. Said, "Can you inject this into my knee? 'Cause it really helped my horse." And I was like,
Yeah. Okay. I got a couple rapid fire questions before we kind of move on to the next. So with the Pentacin, have you, just out of curiosity for my own knowledge, I'm sure some listeners will be interested in this. Have you seen on someone that you just put on Pentacin and, generally speaking, isolated other variables, have you seen any other improvements in their biomarkers?
So you can lower C-reactive proteins definitely with Pentacin.
Okay.
So definitely. And the other thing Pentacin's really useful for is people who have that just a little off kidney function. So Pentacin's actually really useful.
I need to get on this. My kidney's always been a little sluggish.
So it's
and my grandpa got on dialysis.
Yeah. So it's one of the few things we see actually help improve kidney function. So we'll use Pentacin in our poor kidney function people who we can't seem to improve kidney function. They've, some
kind of talk to you offline about working with you guys. I like this. Do you do anything with hyaluronic acid? Like if someone, if someone is experiencing joint pain, cartilage issues, you put them on the Pentacin, you put them on EGCG. What dosage of EGCG, and do you also use hyaluronic acid and curcumin or some things like that?
Yeah. So, so our regimen might be, if you came to me with a painful arthritic knee, is to kind of get you going on some Pentacin, do a 6-week course of Pentacin, and stop it, because the only downside of Pentacin is it's a weak blood thinner. So you can't do a procedure with it. So then what we would usually do is, I love using a combination of either AOD 9064, which is actually a peptide mixed with hyaluronic acid. And AOD 9064 is a peptide that actually it's AOD stands for anti-obesity drug, because in mice it was the cured obesity. If you gave mice AOD 9064, they actually, you couldn't get them fat. You could feed them anything and they couldn't get fat. So people were like, "Oh my God, we found the cured obesity. This is great." Problem is that it didn't work great in humans. It works great in about 3% of humans. So I guess if you have mouse genetics, you do really well. But in the rest of people, it didn't work great. It still works reasonably well in a lot of people at a high dose. But because it has an effect on fat cells, you can actually use it intra-articularly mixed with hyaluronic acid, and you get almost a stem cell-like effect. So some fat lipolysis and almost a stem cell-like effect intra-articularly. So you do actually an injection once a week with the AOD plus hyaluronic acid, which acts as kind of nourishing to the new chondrocytes, and you get this really nice repair. So we'll use Pentacin. We'll then put some, and usually you can put them on epigallocatechins during that period of time too, and then you put the AOD 9064 in, and then you follow that afterwards with this blocking all the bad interleukins so that you can continue that repair process. So usually when I use hyaluronic acid, because otherwise I think it's a temporary fix.
Yeah.
It's nice because insurance pays for it, but otherwise it's a temporary fix. So I'll use it with AOD 9064 because then we get the repair, or I'll use it with what's called a platelet-rich fibrin matrix, where we actually take your blood, spin out the platelet-rich plasma, which all your listeners have heard of, PRP, but then we actually mix it with some fibrin that we extract out of red cells, and we make it into kind of a jelly-like surface, and you put that over like the damaged cartilage, and then you layer the hyaluronic acid. So nope, have to inject it right in. So using ultrasound guidance, we'll inject it right into the joint, like over, like, let's say you have a degenerative meniscal tear in your knee.
Yeah.
You go in right over that meniscal tear. You lay down this cartilage matrix. It's very cool because the platelet fiber matrix stays liquid for long enough for you to kind of get it through a needle, and then it sort of settles into place there where it turns into sort of a jelly-like substance.
Yeah.
And it creates a scaffolding. And then you use the hyaluronic acid, then you inject it next with a little hyaluronic acid. And then that actually kind of nourishes these new chondrocytes. That scaffolding of platelets creates, and then platelets are releasing all these growth factors. Now new cells come into play. You have the hyaluronic acid there nourishing them, and you can actually help to rebuild some cartilage surface. So
is the fibrin kind of functioning to like keep it put?
Keep it in place. Yep. Yeah. So you get, whereas platelet-rich plasma is just a liquid, it's going to rapidly be gone. Yeah. So you get a growth factor effect for about 24 hours. You get much longer effect by using the platelet fibrin matrix. We sort of stole this from the cosmetic people, the plastic surgeons, because they'll use it as filler for the same reason. They'll create the fibrin matrix, use it as filler where it stays there long enough to actually rebuild new tissue. And we said, oh, well, if it works there, can't we use it on cartilage? And indeed, it works quite well. Most doctors don't do that. They just use platelet-rich plasma. But platelet fibrin matrix, you get much better and much longer term improvement. And then during that, then for the next 6 weeks or so, you're going to continue on a Pentacin course, right? Because we want to block all the bad stuff so you can rebuild. And maybe EGCGs or melatonin, your choice, or everything if you want to go for it. And
all gas, no brakes.
Kind of significant improvement in these people over a 12-week period, and hopefully maintained. Remember, if I'm just sticking hyaluronic acid into your joint, I'm not building any new tissue. I'm doing something to help make it feel a little bit better because I'm lubricating the joint, but I'm not really rebuilding tissue. So by doing the hyaluronic acid with either the AOD peptide or platelet fibrin matrix, you can really rebuild tissue and get much better response.
Fascinating. Now, are there any issues you mentioned the Pentacin is an anti-cancer agent. When you talk about like rebuilding tissue and stuff like that, sometimes that has been correlated with increased risk of cancer and certain cancer pathways like mTOR and things like that. Any risk or not so much, or is it kind of offset by the Pentacin?
Those are going to be more things, those are, it's not going to have the same kind of like thymosin beta 4. We always get that concern. Are we really, creating too much growth where it can be unchecked and we don't want to use it continuously? We don't see that with things like Pentacin. It's not working in the same fashion to markedly increase all the IGF, all the growth factors to that degree. So, when you're doing platelets, you do get that increase in growth factor. I don't like doing platelet therapies in somebody who's recently diagnosed with cancer. So I won't do it in somebody who has a recent cancer diagnosis, but I will use it. I don't think you have a risk of inducing cancer. Those are all things that are more growth factor related. So increasing, vascular endothelial growth factor or TGF beta. Those are all things that potentially we think could be related to increasing cancer cell growth. It's pretty hotly debated truly whether that occurs, but we're not doing that big growth factor increase with something like Pentacin.
Gotcha. And you're not like stacking it with all these HGH precursors and things like that, where it's just like guys trying to get jacked look like the racehorse.
Sometimes we do, right? Because we use a lot of peptide therapies. So honestly, if I really want to get somebody healing, do I want to get their growth hormone levels normal? Yes. We don't use HGH because HGH is trickier and harder to get and really expensive and hard to dose. But we use growth hormone secreting peptides, like CJC and ipamorelin, to kind of more get a homeostatic level. And, so we will, if you want to truly heal somebody, trying to normalize all of those levels is going to be important. So if we really, we have a lot of patients who come and they just want to get healthy, we'll piece all of that together.
Last bit, for listeners who are like, I used to take green tea and then I kind of got away from it. What dosage would you recommend for like your average person?
So, when you look at the cancer studies, it's very, very high doses. Which are, when you get above probably 4 milligrams, you have to watch liver functions on people. So I try and keep them below 4 milligrams. My average patient who, I will tell you guys, honestly, epigallocatechins simply for muscle building, just for building muscle and losing fat. If you do simply a milligram a day, you'll see some improvement in a lot of people because of the increase in follistatin with doing nothing else. But, so it depends on the problem. I'll go anywhere from 1 milligram to 5 milligrams a day of, or 1 gram, 1 gram to 5 grams a day of epigallocatechins. On the cancer patients, you want to use it continuously almost. And that's why, like you talked about the melatonin rectal suppository, that's where rectal suppositories are kind of nice because you get more extended release. The problem with the rectal suppository epigallocatechins is they're really hard to get because the cancer patients have bought them up and there's the companies who make them, it's hard to find them. So because cancer is so it can take over so rapidly. You almost need to have epigallocatechins in your system continuously. So we'll have people do, a gram every 3 hours. But even if they go to sleep at night, the cancer will get ahead of them. And so that's why the rectal suppositories were nice if you can get them. But you can pretty safely, if you watch liver functions, go to very high dose epigallocatechins. You just have to, when you're getting into higher doses, have somebody watching your liver.
Yeah, it's interesting too with cancer, where possibly some of those liver side effects could be offset if they're also doing coffee enemas. Okay, this is cool. So before we kind of get into get back to basics, if you will, you're sharing some exciting stuff. Let's talk about, like, on the peptide side, for someone who's interested in keeping their brain sharp and, longevity of the CNS and cognitive function. Where do you find yourself going a lot? I mean, we've got CMAX, like, there's CMAX nasal sprays. There's, I know you're big in the mitochondria, so I don't know if you're using like MOTS-C peptides. What are like your go-to for people that want to keep their brain sharp and they're like, okay, I'm willing to do a little bit of these subcutaneous injections. What are the boulders?
So again, you're kind of going to the fluff when you're talking about MOTS-C, which is an amazing peptide, right? The mitochondrial peptides, humanin, MOTS-C, SS31, those are amazing, but they're difficult to get. They're expensive. So, let's look at the very most basic thing that you can do for your brain, and that's to try and keep IGF levels at a reasonable level, right? So the growth hormone secretagogues raising IGF, so simply using things like CJC and ipamorelin, are always going to be kind of our basis in terms of helping somebody who was starting to have, or just to protect the aging brain. If somebody is more high risk, like let's say if you have ApoE, phenotype or genotype, then pulling in some of the more aggressive peptides might be a reasonable choice. Or you have somebody who's already headed down the path of dementia. Then you've got to think about things like, cerebral lysin, when we could get it, it's been much more difficult to get now. So cerebral lysin was a great peptide for neural function, probably one of the most researched peptides for brain enhancement out of Russia.
How do you spell that?
CEREBROLYSIN.
I've never heard of that one.
No, cerebral lysin's amazing. I mean, it's a BDNF. It increases brain-derived neurotrophic factor, and it's in Russia they use it. It's a prescription that they use post-stroke for neural recovery in their patients, and you can get pretty dramatic improvements in brain function. It's great so somebody who has a early dementia or a genetic history of dementia, we using it on a kind of regular on and off basis was great. It's just now it's gotten to be one of those peptides that's very, very difficult to get. So hopefully we'll have another sources of it at some point, but right now we can't. It's really tough to get. But cerebral lysin is probably one of the was one of our mainstay go-tos for brain function. So we always start with, and then CJC, IPA, and then if you look at the other basic, right, we'll think about what's causing our brain to go bad is all back to kind of that inflammatory piece. And so we always got to get the immune system in check. And so when you go again to the big fancy objects, which are MOTS-C, humanin, let's go back to let's reduce inflammation. Let's get the immune system healthy, because getting the immune system healthy is going to be paramount to every disease process. So we have very liberally, and one of the first peptides we almost always use in patients with disease processes is thymosin alpha-1, because you have to get the immune system healthy or people will actually not ever get better. And the thymic peptides, remember, our immune systems are at their best at puberty. So it's kind of downhill after puberty, sadly. And that's when our thymus glands are at their biggest. So think of your thymus gland, which is, this big gland in your chest, as it's where your T cells go and they learn what to do. And once that thymus gland starts getting smaller, which it starts doing after puberty, and by the time you're my age, it's barely there at all, you've got these sort of T cells gone awry. I always tell people it's a little bit like, these kids coming out of high school going into the army, but the army has no sergeants or nobody in control, and you hand them a gun and say, okay, just go do something. Yeah. And that's what happens without a thymus gland to our immune system. So the immune system gets out of check and it starts not knowing when to attack and what to attack. And so getting back thymic peptides, thymosin alpha-1 being the biggest key there, is really helpful to re-educate those T lymphocytes on what to do, how to act. Stop attacking yourself, start attacking COVID. So that's baseline when you're looking at neural health, instead of going after the Cmaxes and the Clanks, which are great and we use them a ton, but we always have to go back to the basic stuff. Get the IGF levels up, get the inflammation down.
Fascinating. Now, do you use any of the Russian peptide bioregulators? Like I'm using Vladonix right now, which is like, it's basically like thymus.
Right.
Yeah. Are you using that at all or not so much?
So we're not, I think there's some value to them. I think a lot of the oral peptide modulators, there's anecdotal and some of the Russian studies are reasonable. We still have some questions about truly how functional they are. Are they worth the money? I'm still in the, I'm not sure believer camp on some of that stuff.
They're a bit expensive.
They're expensive. I think that you're quite frankly better off going straight to peptide therapies, which are also expensive. But honestly, we know when you're doing these, injectable peptides that have been, at least we sort of know what they're doing in the body pretty well. I'm still at that preference. I think a lot of the biomodulators, bioregulating peptides have been adopted because of the more difficulty getting.
Yeah.
The regular peptides, right? And it's easier to order your stick as you can go to Amazon and order these things, and so I'm not yet convinced. I think there's some value in some of them.
Mm-hmm. Sure. Now, a little bit of a personal question that may have some relevance. Like I'm ApoE E4, which is like the highest risk of right. Alzheimer's and all that right. stuff. And you mentioned that, and it caught my attention because over the years, multiple times I've been prescribed ipamorelin or some of the similar growth hormone precursors. And usually within a month, I'm like super achy and inflamed and I just stop. And I'm like, right. I'm losing flexibility. And I'm like, this clearly isn't a good fit for me. Do you have any idea why or what's going on there? So
we see that a lot. And it's in people who have immune dysregulation. So if you're in an immune dysregulated state and you put somebody on something that upregulates growth factors, they feel shitty. So you've got to get, so we have a lot of people, especially like you, ApoE, where you do nothing but thymosin alpha-1 for a while. You've got to get the immune system stabilized.
I've done that twice. And
sometimes 12 weeks, you do nothing but thymosin alpha-1, and then you start adding in small doses, and you'll be surprised how much better you tolerate it. But that always indicates to us some underlying immune dysregulation when we see that, because there's no reason that CJC and IPA, unless they're getting it from a bad source, which is always a possibility too. But if you're getting it from a good reputable source and there's not crap in it, then it's because you're having an immune reaction that you shouldn't be having, meaning you have a dysregulated immune system.
Totally. Yeah. And I was diagnosed with Lyme disease in 2011 and then got bit by 3 ticks this past year.
So you've got 12 weeks if you do nothing but TA1 and maybe BPC, but BPC 157. But
I was going to ask you about that.
Immune modulation. That's all you do for 12 weeks in these people, and we have tons of people like that. We don't touch somebody with an inflammatory disorder like Lyme disease with the growth hormone secretagogues until we've stabilized their immune system. You've got to do that first, and we've made those mistakes. I mean, you're like,
that's huge. That's huge. And is that something that is weight? Is the dosage based on size, or is it standard for most people?
Well, thymosin alpha-1 has no ceiling dose. You can use as much of it as you can afford. In the COVID patients, so there's studies now using thymosin alpha-1 to treat COVID. In other countries, it's a drug. It's called Xidaxin. So it's a drug that they put all their immune compromised people on. They put their chemotherapy patients on.
Yeah, my brother used it to help with his Lyme disease and get his immune system back.
And here
you may still be using it.
Yeah, and here we can't get it as a drug. We haven't made it as a peptide thymosin alpha-1. You can use high doses. One of my sons got COVID, got actually really sick. And we were giving him, massive doses. Stabilize, sort of a regular dose, you can use like 450 micrograms. But you can go up to, 10 times that safely if somebody's really sick. So we base it a little bit on weight, a little bit on disease process, a little bit what we're treating, a little bit on what people can afford. The biggest downside of peptides is their cost. But you've got to get that whole piece in order, otherwise, and again, I've seen your story over and over and over again.
Yeah. No, this is fantastic. You're dropping.
But we used to put all of our ApoE4 people on cerebral lysin, just say, you just need to do this like 3 times a week the rest of your life, because cerebral lysin's been shown to be so neuroprotective. You might still be able to get it from Russia. It's just expensive and hard to get. Yeah, but that's the country that makes the most of it.
I'm interested in that. Are you using it right now?
I can't get it. I can't afford it.
Yeah.
I can't get it. I did. So I'm not ApoE, but all my husband is, and all my kids are. So I had all of them taking cerebral lysin, but then I couldn't afford it for all of them. And then I was like, well, I don't know which one I like the best. So
Yeah. Gotcha.
It wasn't my husband. He was
Yeah, he's out. I mean, you were trying to
he was low on the list.
Yeah. He got dropped immediately, but then you felt bad because you couldn't pick which
I
kid.
felt bad. I have 5 kids. I couldn't decide which one.
Yeah. Just eat your vegetables, kids, or your meat. Carnivore's really popular right now. Let's talk about let's get back to basics, because you see a ton of people, and you were telling, maybe you could share like just a little anecdotal story that kind of summarizes the pattern that's been walking into your office a lot lately.
So I think this is what I'm seeing more and more, because this whole biohacking world is growing phenomenally, right? I mean, nobody knew the word, a year ago. And I was watching a Good Doctor episode the other day, and this guy had done CRISPR on himself, and they had this whole biohacking episode.
Imagine launching a company called Biohacking Secrets in 2016. It was a lot of explanation.
Yeah, exactly. And now it's become where it's taking off. I mean, how many biohacking groups do you see on the internet? There's tons, right?
Yeah.
And so what we're seeing now in this advent of all these, and the advent of social media, so people are more exposed to it. I have all these people coming in, and they think they are the bomb. Here's their regimen. I was telling you about, people come in with the spreadsheets of literally graphic of, what they're doing. And, thousands and thousands of dollars a month, where, with their infrared saunas and their cryofusions and their NAD infusions, and their, and this exercise protocol and all these things. And that stuff's all super cool. I mean, the Instagram post of you in your cryofusion chamber is really cool. But what we're seeing is those people come in, and I run their labs, and they don't look healthy. It's because you got to still not forget that the stuff we've been doing to kind of fix the basics, even though we may not have been even knowing exactly why it was as helpful as what we do now, is still going to be paramount. So, for example, if we kind of go down to everything is back to cell health. So medicine was all disease focused. So that's still what medicine mostly is disease focused, right? You go in and you have liver disease, you have cancer, whatever. And then we went down to, it's not disease focused, it's organ system focused. You have adrenal dysfunction, you have thyroid dysfunction. We have to fix the organ system that's dysfunctional. We have to fix the microbiome of the gut. Everybody's, got into that. Well, now we're getting down deeper, and I'm involved with this group, this SEED Scientific Research and Performance Group. And it's kind of, he's doing a fellowship, but there's 25 kind of mastermind docs, and we meet quarterly. Is this
Dr. Seeds?
Yeah, Dr. Seeds.
Okay, yeah.
And he and I work closely together, and I'm faculty with this group, and we're actually working. We have 25 kind of mastermind doctors. We meet quarterly, and we just bounce around all this stuff. But Dr. Seeds is kind of
great.
A savant on metabolic pathways and cell pathways and cellular health.
He's been a big proponent of BPC 157. He's got some other products like Chill Pill and things like that.
Yeah, I don't think he's involved in those anymore.
Oh, really?
He's kind of gotten off that. He's kind of he sort of realized that he didn't want to sort of be, he didn't want to be product equated, because he really wanted to just say, I'm not pushing any products. I'm simply pushing health. And so he kind of, gave up a lot of money, but decided he didn't want.
Was that because of potential litigation?
No, it was really honestly because he realized it was sort of clouding where he wanted medicine to go, which was to get away from, it used to be that doctors, and still are to some degree, are run by pharmaceutical companies. Well, now, unfortunately, we're seeing the functional medicines being run by the supplement companies, right?
Yeah,
everybody's now trying to sell their supplement or sell their product. And he said, I don't want to be seen as what I'm doing selling products.
Yeah.
I want it to be seen as what I'm doing is understanding health. Yeah. So he actually gave up millions of dollars to actually say, I'm not going to abandon that, and I'm going to go a different direction, and I'm going to actually focus on trying to teach what we know is going to be important for health span, and that's cellular health. So our focus has really been now on taking things now from that functional medicine level down to a cellular health level, and so this fellowship group is one of the few places that's actually being taught. But we're looking at metabolic pathways, and particularly my fascination has been mitochondria. And I just gave a lecture for Leukemia and Lymphoma Society on mitochondria in cancer, but probably all of our disease processes are going to come down to a dysfunction at the mitochondria. So, if you look at cancer, for instance, we used to say, well, cancer is a a genetic mutation or, something causes damage to a cell. Well, interestingly enough, if you take a cancer cell and you take healthy mitochondria and you put that into the nucleus of the cancer cell becomes normal. And if you take the nucleus, the mitochondria out of the nucleus of a cancer cell and you put it into a normal cell, it becomes a cancer cell. And so we know that it's the mitochondria that's actually even carrying that information. So mitochondria are probably responsible for almost all of health. So if you think about the organ systems that go awry in us, probably the worst as we age, we lose muscle, we lose our brains, we lose our cardiac function. So those are the three organ systems that are probably most susceptible to aging. They're all also the most energy demand organ systems, right? Our brain, our heart, and our muscle are the ones that are using up most of our cellular energy, our ATP. So you start exhausting and damaging mitochondria, and those start dying off, and subsequently it's a downhill play from there. So what we're focusing on now is how do we fix the cell and ultimately fix the mitochondria? And I've struggled a little bit because I have people come in, I say, well, why then do I want to look at your hormones if really I just have to fix your mitochondria? And the spikes, well, I'm doing cryofusion, that fixes my mitochondria. So here's the interesting thing that you and I talked a little bit about.
Not if you're loaded with heavy metals.
Right. I mean, so you have to go back to, okay, mitochondria actually have receptors for hormones on them. People don't know that. But so your mitochondria cholesterol, there's a receptor called the STAR receptor that actually takes the cholesterol and inside the mitochondria turns it into pregnenolone, and hence for men, that's their primary source of progesterone. So if you don't have healthy mitochondria, you can't actually convert your cholesterol into pregnenolone, which is important for brain function, and progesterone, which is important for brain and inflammation. You can't do that anymore if your mitochondria aren't healthy. And so we've got to go back to how do you fix the mitochondria? Well, first, there's this vicious cycle when hormones drop. So there's thyroid receptors on the mitochondria. There's estrogen receptors on the mitochondria. So if I have no estradiol, so if you're a guy and you're taking testosterone and you've blocked too much of your estrogen, right? Too much estradiol. There's E2 estradiol receptors on the mitochondria. And the E2 receptors on the mitochondria, when there's enough estradiol, triggers what's called the unfolded protein response, or UPR, inside the mitochondria. Now, unfolded protein response is one of our big mitigators of getting rid of damaged proteins and repairing them. So getting rid of the really damaged ones and repairing the ones that are reparable. And so if I have no E2, my unfolded protein response in my mitochondria gets turned off, and now I can't repair proteins. So now I have all these bad proteins that are now damaging my vascular system or my liver or my kidneys or whatever it might be. So you've got to first repair the estrogen, right? Repair the thyroid, repair all of those pieces. That's going to now get the mitochondria starting to be healthy. So I'm actually get mitochondria that are starting to function more normally. But ultimately, we also have to get rid of the bad mitochondria that are already damaged, right? So that's where that whole mitophagy or autophagy piece is. Kill off the bad stuff.
Yeah. So is part of that you're having them do like longer fasts and some senolytics, maybe with quercetin or T-theoflavins, or what's going on there? What do you do?
So I think all of those things work. So intermittent fasting, definitely helpful. Even time-restricted eating. We don't really know how long a fast you have to do. Everybody says, oh, it's 48 hours, 72 hours. Oh, you have to do at least 5 days. Actually, if you look at the data, there's not a lot to say that just doing time-restricted eating doesn't have the same value.
Yeah,
I'm a proponent of periodically doing longer fasts, but I don't know that that's necessarily been proven as the right choice.
Yeah, and it sometimes sucks for productivity.
Right. And I have some people who just honestly can't tolerate it. And I have some athletes who really can't tolerate it. Yeah. So I'm a big proponent, however, of time-restricted eating, of going just at least sort of a 12 to 16-hour period. Yeah, 16-hour fast, I think, is hugely beneficial for autophagy.
Yeah,
and then all the things you're talking about, our favorite go-to now anymore, interestingly, for autophagy, because it has so many other benefits, is spermidine. So really? I don't know if you're familiar with spermidine.
I just ordered some yesterday.
Yeah, spermidine's amazing.
Yeah.
So spermidine's a polyamine.
Yeah.
And we know that polyamines are found in two places of really high quantity. One's in semen. So, anything that's there to protect the gamete has to be really important, right? And the other place is breast milk. It's in huge volumes of breast milk. So, those are places that they're essential to health. But polyamines at high levels are found in every single organism. We know that the higher your polyamine level is, the healthier you are, the longer you live. We couldn't even get polyamines, couldn't get spermidine here until about recently. I mean, 6-7 months ago. It was only available in Europe and they wouldn't ship it here. So we've only been able to get it here recently. But it's polyamines, particularly spermidine, are really super critical to health. So they do two things. Number one, they actually cause autophagy, so they get rid of the bad cells. But number two, they cause mitochondrial biogenesis. So now they take the good mitochondria and they make more of them. So you're actually now, so I've given now all this stuff to the mitochondria, it has all its hormones normal, right? So it can self-regulate. And so I've gotten the hormones, the nutrients, all that it needs. I kill off the bad stuff by using usually high-dose spermidine for a period of time, because that's going to kill off the bad stuff and then start causing a rapid mitochondrial biogenesis. So now I'm replicating the good cells.
What's high dose? Because I just bought a couple bottles of this stuff.
So 1 milligram is a standard daily dose. We'll go up to 4 to 5 milligrams for a period of time, depending on how sick people are, to go through a real big autophagy phase if I have somebody who's really sick.
You do that every day?
So usually I'll do that like 4 milligram a day for a 6-week period, sometimes only a 3-week period. It's pricey, so that's the biggest downside.
Yeah, it is. It is.
They are coming out with a physician-only version that's a higher dose, so hopefully that'll be a little more cost-effective for patients. But our sick patients who have high inflammatory markers will do that for as long as 6 weeks, sometimes if they can afford it. And then a maintenance dose, like I always do 1 milligram a day, so 2 caps, 1 a day, because that's actually going to just, now, once I've gotten rid of all the bad stuff, I've gotten this good mitochondrial biogenesis. Now I just have to self-regulate it, right? I have to keep that going. So I have to keep the hormones stable. I stay on a low-dose polyamine or a reasonable dose polyamine to keep that process at a stable level. I mean, people take all these antioxidants, right? Well, think of what you're doing. So the thought being, wow, you have these damaged mitochondria and they're spilling out all these free radicals. And so I'm just going to take tons of stuff to get rid of the free radicals. Well, that's stupid, because really you've got to fix the mitochondria so they're not spewing out free radicals. Then now I'm taking another drug to get rid of the free radicals. Yeah. We know that some degree of free radicals is really important to the mitochondria. It turns on those mitochondrial peptides, right? Mm-hmm. So humanin, MOD-SC, SS31 are all mitochondrial stress peptides. So you want low-level stress for the mitochondria to produce those really life-saving mitochondrial peptides. So I think people get a little backwards. They're treating all these free radicals instead of saying, let's fix the mitochondrial problem in the first place.
I totally agree. What one of the things with mitochondria that's a little bit tricky is, like, I don't know, and you're probably going to enlighten me, but I don't know of any blood test that's great for checking mitochondrial health. You know, you've got like the bioenergy testing that's looking at gas exchange, and we were doing that for a while with clients, and I found a bunch of problems with it. Like, you know, you can use proxies like breath hold times and stuff, or phase angle. But like, what if someone wants to check the status of their mitochondria? Where do you look?
So I think that's hard. So I think, you're right. That's a little bit more difficult to look at oxidative phosphorylation and energy pathways. And I think it's going to be putting together a whole lot of data to do that. I think where we'll go is more looking at proteomics for that, where we can actually now isolate these proteins, these secretory proteins that are produced by damaged mitochondria, and look at that load. So I think what we'll probably be starting to do at some point, so there's a company called SomaLogics that does proteomics. So it actually looks at all the protein that are, so we first went from genomics to epigenomics, so your epigenome, and now to proteomics and metabolomics. It's how the proteins metabolize, but looking at protein markers. So now we can look at these sort of secretory protein markers that indicate damaged mitochondrial load and sort of damaged cell load in general. And that's what I think we're getting to, is be able to run these blood markers that look at the proteins that can tell us mitochondrial function a little bit more. Like, we can actually, interesting enough with proteomics, we can actually give you your body fat composition equal to a DEXA scan. So isn't that interesting? And you can get VO2 max from proteomics.
Come on.
Instead of doing, just from your protein markers.
This is like a blood test or a saliva test?
Yeah, it's a blood test.
Wow. Yeah, that's a lot easier than going to get a scan.
Yeah, much easier. Like, doing VO2 max is a pain in the ass test to do, right?
Yeah. And you got to work out, right?
And it's probably an important marker when you think about ATP and energy production. Probably a VO2 max is a relatively important marker of that. And if that's declining, probably something is going on with ATP production, hence mitochondrial function. So if we can do a protein marker and just look at that, as opposed to having somebody run in the lab, with a thing on their face and run on the treadmill, that's going to be a whole lot simpler. So we already know we can do those things. We can look at, we can look at tons of that information just from protein markers. So I think in the very near future, and we're trying to, work with this a little bit with, kind of doing our own studies, but also working with a company called Deep Longevity, which is actually a Russian company that actually is being able to take tons and tons of data that we feed them and sort of pick out the pieces of, okay, everybody who has this disease, so we can take somebody we know has horrible mitochondrial disease. There's people who, have very, very diagnosed mitochondrial disease from skeletal biopsies, things like that. We can say this marker is really high or really low in them. And so this is where computers are going to be so useful to us, because we can take all of this data, feed it into a computer, and it can spit us out. Okay, look at this. So I think proteomics is going to be probably the answer there. We're not there yet, but we'll get there soon, I think.
This is fascinating. I mean, I definitely would love to work with you guys and do that course of thymosin alpha and pentosin and some of those things. For the people listening that feel the same way, what's the best way? Like, we're going to come back to a few more of the basics, but I want to give a little, for people that want to reach out to you and possibly work with you, how do they do that?
So if you just go to boulderlongevity.com, there's tons of information on that site about our peptide program, about our optimization program. There's a great talk if you click on the Human Optimization Academy. So there's sort of an academy, and then sort of become a member of Human Optimization Academy. That's where we're actually posting a lot of this information about penicillin. There's a talk on there on beyond stem cells and platelet cells where we talk about penicillin. And there's a couple of talks on arthritis. That's one of my fascinations, obviously, since my background's orthopedics. So one of my fascinations is, and here's a disease that honestly we've made very little progress on osteoarthritis, right? All we do is stick steroids in somebody until we replace a joint. We've made very little progress on it. And I think this is a place where we need to really focus, because it's debilitating for tons of people. I mean, my dad, he died recently at 91, but his last few years, he was crippled by arthritis, right? I mean, he was healthy in every other way, but had horrible arthritis that for him, who could climb 14ers at 80, was horribly devastating. So I think this is a disease we need to focus on some more. So there's some good talks in there. So go to boulderlongevity.com. You can follow me at Dr. Yurth on Instagram. We post a lot of stuff there. These podcasts are great. I do a lot of podcasting, and so you can look for me there as well, because we try and share this information. I know, you guys are out there trying to find places to get this stuff, but we will try and curate it for you in that Optimization Academy, because there is so much out there, some of it good, some of it not so good. We do try and curate that. I spend a lot of time just reading and trying to put it out for you guys in sort of digestible forms.
Yeah, no, this is fantastic. And you've already shared so much great stuff today, and I appreciate it. Thank you. I'm sure our listeners do as well. A little bit of a question about my father. He was diagnosed with Parkinson's 5 years ago. Obviously, we know that I'm E4.
Right.
We're currently doing NAD suppositories, high dose melatonin periodically, ETDA to chelate some heavy metals. He had the mercury fillings. We took those out. We took care of his root canals, but we haven't done anything to chelate the metals. So we just got that going. I'm administering a substantial amount of suppositories to my father. I never thought that would be the case. and we're doing transcranial magnetic stimulation with the BrainsWay machine. Does anything else come to mind? I mean, neurodegenerative disease is off the chart, so I'm sure a lot of our listeners have loved ones that may be in a similar position.
So look up a peptide called dihexa, DIHEXA. So dihexa actually has been investigated by Michael J. Fox Association. It actually is really quite marked in its benefits for Parkinson's. And I'm not sure what stalled it, but it was almost going to come to market as a drug for Parkinson's. If you look at the research, it was very compelling, and then somehow fell off the wagon. So I'm not, you always get wonder what happens when those things, but it's a very, very safe peptide. It's actually a transdermal cream. So you use it as transdermally, which is nice because you don't have to inject it in. Again, downside expense and sometimes difficulty getting, but it can have some very marked benefits for Parkinson's patients. So dihexa, and again, there's some research through the Michael J. Fox Association on dihexa. So it's actually got some really valid research behind it, even in human populations. A lot of our peptides are well proven in mice and a little less well proven in us, but dihexa actually has some really good human studies on it. I love dihexa for my Parkinson's patients. It's, again, downside is cost. And when you get into these peptides, especially the doses you need, sometimes for these disease processes, cost becomes a factor. And if you can get cerebrolysin, it's hugely beneficial there as well, because both of those are really reparative peptides for brain function. So you can see really marked improvements with that as well. But dihexa is probably the most researched peptide in terms of treating Parkinson's. And again, there's some pretty nice data out there about it.
Beautiful. Thank you so much. And then to kind of land this plane, we were chatting before we started recording about blood tests and where a lot of people are focusing on the wrong areas.
Right.
What blood tests do you feel everyone should be getting? Where should they be focusing their attention, and why?
So here's one of my pet peeves. I literally have people come in with a 3-ring binder of the blood test their functional medicine doctor has ordered that is this thick. And they've really literally are paralyzed by information. They've done nothing with them, neither as a functional medicine doctor, except maybe, said, oh, you need more probiotics.
To honor all is to honor none.
So it becomes a little bit like, okay, where do you start? So I do want to encourage you guys, if you get a good physician who knows what, and we're trying to teach this to you too. So we're trying to put together a course so you can understand your own blood work a little bit better. But there is so much valuable information in simply your CBC and your CMP. These are $12 tests. So complete blood count and a comprehensive metabolic panel. You can get a whole lot of information. For instance, to look at immune function. You can do all these T cell studies and all these things, but I can look at a white blood count and then I can break it down. And for instance, white blood counts are broken down into neutrophils, lymphocytes, monocytes, basophils, and eosinophils. And the goal is to have not a lot of the inflammatory cells, the monocytes, the eosinophils, and basophils, and have most of those white cells in neutrophils and lymphocytes. In an ideal, if you were the perfectly healthy, perfectly thymused 18-year-old, you would have a neutrophil to lymphocyte ratio of about 1-to-1. As we get older, the lymphocytes start to drop and that ratio starts to increase. So most of the people who are my age, it's like 3-to-1. So we know that we're starting to get this immune or inflammation, this immune aging process, which is probably the root of getting sick from COVID and dying. And so so you can look at that simple ratio, a neutrophil to lymphocyte ratio, and say something about, your immune system's not so good. There's low-grade inflammation. That's way before your C-reactive protein starts going up. People are like, oh, my C-reactive protein's fine. That's way before your C-reactive protein starts going up. The other thing is looking at things like the size of the cells. One of the pieces that correlated very markedly with cell age was the mean cell volume, the MCV. And the only thing your doc has ever learned about MCV is that a high MCV means you probably have a B12 deficiency. There's a whole lot more that goes behind the size of your cells. But again, that healthy 18-year-old has a mean cell volume in the 80s. As we get older, it gets higher and higher and higher. Our goal is to keep that number in that 90 level. So because that as the bone marrow, as the stem cell population starts to fatigue, as we start to get older and we don't have nice bone marrow regeneration anymore, then that size, the red cells are bigger and bigger. And we don't get this nice diffuse cell variation in cell size. So the mean cell volume, our goal is to keep that number on the lower side. Most people, that number is going to look 95, 96. Is that okay? Yeah, it's fine. It's not at the level that shows that you have a really good, healthy cell age or biologic age, right? The other thing is like on the metabolic panel, things like, that get ignored, albumin. There was a great study that actually looked, they could predict people who were going to die in the hospital versus get out of the hospital simply based on their albumin levels. And the lower the albumin level got, the less likely that person was to get out of the hospital alive. Well, the same thing's true about us. So as our albumin levels drop, it could be dietary, it could be you eat no protein, but more likely it's that you don't have normal cell function to utilize the protein and have normal albumin levels. So it's a marker of sort of cellular health. And so when we see that number get below 4.6, 4.5, and maybe the total protein's still fine, but the albumin level is low, something's going on. Sometimes it's low copper, sometimes it's stress, and so then you got to put this all together. There's a whole bunch of pieces to this puzzle that are in a $12 lab test that I can start with and follow very easily. I could do these big methylation, DNA methylation age tests, and they're $600 each pop. And so every time I do something different,
you're talking like a Horvath clock or something like that.
And Horvath, the True Age and Cone Age and all those, and they're great tests. They're really cool tests. They give you a ton of information, but they're expensive. So if I do it once and I can't repeat it for a year, do I really know if something I did, like I did a peptide, did it change things or not? I need to have something more simple to look at. So starting with simply CBC, CMP, looking at hormones to make sure they're all optimal, because remember, that's really important for those mitochondria to have normal hormone levels, and looking at the micronutrient panel. From those 4 things, I can discern what is your gut health like what else, you don't need to have every single allergy test done. We'll use those tests sometimes, but you've got to start with some very basic stuff. And I see people with, tons of data, and we don't need all that data. We need your symptoms. We need to go back to kind of the old days of what is that patient telling me? What am I seeing? And what are some of the basic clues on their blood tests that tell me what's going on?
This has been fantastic. What a great interview. I've enjoyed it immensely. It's boulderlongevity.com.
Yep, boulderlongevity.com.
boulderlongevity.com if you'd like to work with Dr. Yurth or check out some of those resources that she mentioned. Dr. Yurth, thank you so much for sharing your wisdom. Is there anything else that you're really excited about that's working that you want to kind of plant a seed in the brains of our listeners to encourage them to maybe help optimize themselves and focus on the shouts, not the whispers?
No, I will tell you, I have no investment in spermidine, but honestly, of all the supplements, if I were to say I would take one thing, that's what it would be, because I think it's working at a very, very, very basic level to repair cell health. And then we're seeing really marked improvements in a whole lot of parameters on our patients who we put on spermidine. It's one of those, you can play a fun game, Google spermidine in any disease process, and you'll see there's studies to connect it. So it's one of those almost too good to be true, but that's because it's working at the mitochondria to repair the mitochondria. And that's what you come back to. If you do that, are we fixing all these other diseases? Maybe. So that would be my kind of take home. Look into that supplement. The company that there's not a lot of companies that ship it here to the U.S. Spermidine Life it's an Austrian company, but they do ship here now. It's what's called a complete polyamine. Meaning it has spermidine, putrescine, and kind of in all it's kind of like a complete CBD versus just one piece of CBDs. You really want the complete polyamine complex, and so.
That's hilarious that I ordered that yesterday, and then this is the first times we've talked about it on the podcast too.
Yeah, and hair growth, honestly, that's one of the if spermidine and hair growth for guys who are losing hair, or women who are losing hair, spermidine really helps with hair growth too. It's kind of a remarkable supplement. It is one of my mainstays anymore. Its big downside, a lot of the stuff is cost, but if I'm going to spend money, it's actually right now where I put my money, because I sort of feel like if I fix that, and I'll tell you, so one of the things I track on myself is, just use my Oura ring, just my HRV, right? So we know that heart rate variability, heart rate variability is it matches cell age pretty nicely. Mm-hmm. So you can actually now, tag, okay, I started taking spermidine fall. See, my heart rate variability improved dramatically, actually, just with spermidine. And so I'll do things like, I'll do nothing but one supplement and see what happens with my respiratory rate, my HRV, my deep sleep, and track those little markers, because those are also simple things that we are making a change, right?
Lovely, lovely. Well, Dr. Yurth, this has been a pleasure. It's not often, I don't want to sound like a cocky asshole, but it's not often that I'm learning a lot of new things on a podcast, and I did. This was exciting. And thank you so much. Guys, if you would like to work with Dr. Yurth, go to boulderlongevity.com. And Dr. Yurth, I'll talk with you offline about possibly exploring some of this stuff that you turned me on to. Thank you.
Okay.
Bye-bye.
Thank you for having me. Bye.